Medical Surgical Nursing Exam 8. Mr. Duffy is admitted to the CCU with the diagnosis of arrhythmia. He presented in the ER with a typical description of pain associated with me, and is now cold and clammy, pale and dyspneic. He has N4 of D5W running, and is complaining of chest pain. Oxygen therapy has not been started, and he is not on the monitor. He is frightened. Question 1. The nurse is aware of several important tasks that should all be done immediately in order to give Mr. Duffy the care he needs. Which of the following nursing interventions will relieve his current myocardial ischemia? A. Stool softeners, rest. B. O2 therapy, analgesia. C. Reassurance, cardiac monitoring. D. Adequate fluid intake, low-fat diet. Answer: B. O2 therapy, analgesia. All the nursing interventions listed are important in the care of Mr. Duffy. However, relief of his pain will be best achieved by increasing the O2 content of the blood to his heart, and relieving the spasm of coronary vessels. Question 2. During the first 3 days that Mr. Duffy is in the CCU, a number of diagnostic blood tests are obtained. Which of the following patterns of cardiac enzyme elevation are most common following in me? A. SGOT, CK, and LDH are all elevated immediately. B. SGOT rises for 6 hours after infarction with CK and LDH rising slowly 24 hours later. C. CK peaks first 12-24 hours, followed by the SGOT peaks in 24-36 hours and then the LDH peaks 3-4 days. D. CK peaks first and remains elevated for 1 to 2 weeks. Answer: C. CK peaks first 12-24 hours, followed by the SGOT peaks in 24-36 hours and then the LDH peaks 3-4 days. Although the timing of initial elevation, peak elevation, and duration of elevation vary with sources, current literature favors option letter C. Question 3. On his second day in CCU, Mr. Duffy suffers a life-threatening cardiac arrhythmia. Considering his diagnosis, which is the most probable arrhythmia? A. Atrial tachycardia. B. Ventricular fibrillation. C. Atrial fibrillation. D. Heart block. Answer: B. Ventricular fibrillation. Ventricular irritability is common in the early post-me period, which predisposes the client to ventricular arrhythmias. Heart block and atrial arrhythmias may also be seen post-me, but ventricular arrhythmias are more common. Question 4. Mr. Duffy is placed on digitalis on discharge from the hospital. The nurse planning with him for his discharge should educate him as to the purpose and actions of his new medication. What should she or he teach Mr. Duffy to do at home to monitor his reaction to this medication? A. Take his blood pressure. B. Take his radial pulse for 1 minute. C. Check his serum potassium K level. D. Weigh himself every day. Answer: B. Take his radial pulse for 1 minute. All options have some validity. However, option B relates best to the action of digitalis. If the pulse rate drops below 60 or is markedly irregular, the digitalis should be held and the physician consulted. Serum potassium levels should be monitored periodically in clients on digitalis and diuretics, as potassium balance is essential for prevention of arrhythmias. However, the client cannot do this at home. Daily weights may make the client alert to fluid accumulation, an early sign of CHF. Blood pressure measurement is also helpful, providing the client has the right size cuff and he or she and/or significant other understand the technique and can interpret the results meaningfully. Question 5. You decide to discuss glaucoma prevention. Which of the following diagnostic tests should these clients request from their care provider? A. Fluorescent stain. B. Snellen's test. C. Tonometry. D. Slit lamp. Answer: C. Tonometry. Option A is most often used to detect corneal lesions. B is a test for visual acuity using Snellen's chart. D is used to focus on layers of the cornea and lens looking for opacities and inflammation. Question 6. You also explained common eye changes associated with aging. One of these is presbyopia, which is A. Refractive error that prevents light rays from coming to a single focus on the retina. B. Poor distant vision. C. Poor near vision. D. A gradual lessening of the power of accommodation. Answer: D. A gradual lessening of the power of accommodation. Option A defines astigmatism, B is myopia, and C is hyperopia. Question 7. Some of the diabetic clients are interested in understanding what is visualized during funduscopic examination. During your discussion you described the macular area as A. Head of the optic nerve, seen on the nasal side of the field, lighter in color than the retina. B. The area of central vision, seen on the temporal side of the optic disc, which is quite avascular. C. Area where the central retinal artery and vein appear on the retina. D. Reddish-orange in color, sometimes stippled. Answer: B. The area of central vision, seen on the temporal side of the optic disc, which is quite avascular. Options A and C refer to the optic disc. D describes the color of the retina. Question 8. One of the clients has noted a raised yellow plaque on the nasal side of the conjunctiva. You explained that this is called A. Apincula, which is normal slightly raised fatty structure under the conjunctiva that may gradually increase with age. B. Icterus, which may be due to liver disease. C. Pterygium, which will interfere with vision. D. Ciliary flush caused by congestion of the ciliary artery. Answer: A. Apincula, which is normal slightly raised fatty structure under the conjunctiva that may gradually increase with age. Correct by definition. Question 9. You know that all but one of the following may eventually result in uremia. Which option is not implicated? A. Glomerular disease. B. Uncontrolled hypertension. C. Renal disease secondary to drugs, toxins, infections, or radiations. D. All of the above. Answer: D. All of the above. Options A, B, and C are potential causes of renal damage and eventual renal failure. Individuals can live very well with only one healthy kidney. Question 10. You did the initial assessment on Mr. Kaplan when he came to your unit. What classical signs and symptoms did you note? A. Fruity smelling breath. B. Weakness, anorexia, pruritus. C. Polyuria, polydipsia, polyphagia. D. Ruddy complexion. Answer B. Weakness, anorexia, pruritus. Weakness and anorexia are due to progressive renal damage. Pruritus is secondary to presence of urea in the perspiration. Fruity smelling breath is found in diabetic ketoacidosis. Polyuria, polydipsia, polyphagia are signs of DM and early diabetic ketoacidosis. Oliguria is seen in chronic renal failure. The skin is more sallow or brown as renal failure continues. Question 11. Numerous drugs have been used on Mr. Kaplan in an attempt to stabilize him. Regarding his diagnosis and management of his drugs, you know that A. The half-life of many drugs is decreased in uremia, thus dosage may have to be increased to be effective. B. Drug toxicity is a major concern in uremia, individualization of therapy and often a decrease in dose is essential. C. Drug therapy is not usually affected by this diagnosis. D. Precautions should be taken with prescription drugs, but most OTC medications are safe for him to use. Answer B. Drug toxicity is a major concern in uremia, individualization of therapy and often a decrease in dose is essential. Metabolic changes and alterations in excretion put the client with uremia at risk for development of toxicity to any drug. Thus alteration in drug schedule and dosage is necessary for safe care. Question 12. The point of maximum impulse PMI is an important landmark in the cardiac exam. Which statement best describes the location of the PMI in the healthy adult? A. Base of the heart, 5th intercostal space, 7 to 9 cm to the left of the mid-sternal line. B. Base of the heart, 7th intercostal space, 7 to 9 cm to the left of the mid-sternal line. C. Apex of the heart, intercostal space, 7 to 9 cm to the left of the mid-sternal line. D. Apex of the heart, intercostal space, 7 to 9 cm to the left of the mid-sternal line. Answer C. Apex of the heart, intercostal space, 7 to 9 cm to the left of the mid-sternal line. The PMI is the impulse at the apex of the heart caused by the beginning of ventricular systole. It is generally located in the 5th left ICS, 7 to 9 cm from the MSL or at, or just medial to, the MCL. Question 13. During the physical examination of the well adult client, the healthcare provider auscultates the heart. When the stethoscope is placed on the 5th intercostal space along the left sternal border, which valve closure is best evaluated? A. Tricuspid. B. Pulmonic. C. Aortic. D. Mitral. Answer A. Tricuspid. The sound created by closure of the tricuspid valve is heard at the 5th licks at the LSB. Pulmonic closure is best heard at the 2nd licks, LSB. Aortic closure is best heard at the 2nd licks, RSB. Mitral valve closure is best heard at the PMI landmark apex. Question 14. The pulmonic component of which heart sound is best heard at the 2nd licks at the LSB? A. S1. B. S2. C. S3. D. S4. Answer B. S2. S1 is caused by mitral and tricuspid valve closure, S2 is caused by the aortic and pulmonic valve closure, S3 and S4 are generally considered abnormal heat sounds in adults and are best heard at the apex. Question 15. The coronary arteries furnish blood supply to the myocardium. Which of the following is a true statement relative to the coronary circulation? A. The right and left coronary arteries are the first of many branches off the ascending aorta. B. Blood enters the right and left coronary arteries during systole only. C. The right coronary artery forms almost a complete circle around the heart, yet supplies only the right ventricle. D. The left coronary artery has two main branches, the left anterior descending and left circumflex, both supply left ventricle. Sally Baker, a 40-year-old woman, is admitted to the hospital with an established diagnosis of mitral stenosis. She is scheduled for surgery to repair her mitral valve. Answer: D. The left coronary artery has two main branches, the left anterior descending and left circumflex, both supply the left ventricle. The right and left coronary arteries are the only branches off the ascending aorta. Blood enters these arteries mainly during diastole. The right coronary artery also often supplies a small portion of the left ventricle. Question 16. Miss Baker has decided to have surgical correction of her stenosed valve at this time because her subjective complaints of dyspnea, hemoptysis, orthopnea, and paroxysmal nocturnal dyspnea have become unmanageable. These complaints are probably due to A. Thickening of the pericardium, B. Right heart failure, C. Pulmonary hypertension, D. Left ventricular hypertrophy. Answer: C. Pulmonary hypertension. Pulmonary congestion secondary to left atrial hypertrophy causes these symptoms. The left ventricle does not hypertrophy in mitral stenosis. Right heart failure would cause abdominal discomfort and peripheral edema. Pericardial thickening does not occur. Question 17. On physical exam of Miss Baker, several abnormal findings can be observed. Which of the following is not one of the usual objective findings associated with mitral stenosis? A. Low-pitched trembling diastolic murmur, precordial thrill, and parasternal lift. B. Small crepitant trails at the bases of the lungs. C. Weak, irregular pulse, and peripheral and facial cyanosis in severe disease. D. Chest X-ray shows left ventricular hypertrophy. Answer: D. Chest X-ray shows left ventricular hypertrophy. Ventricular ischemia does not occur with prolapsed mitral valve. Options B and D are not painful conditions in themselves. Question 18. You are seeing more clients with diagnoses of mitral valve prolapse. You know those mitral valve prolapse is usually a benign cardiac condition, but may be associated with atypical chest pain. This chest pain is probably caused by A. Ventricular ischemia, B. Dysfunction of the left ventricle, C. Papillary muscle ischemia and dysfunction, D. Cardiac arrhythmias. Answer: C. Papillary muscle ischemia and dysfunction. Ventricular ischemia does not occur with prolapsed mitral valve. Options B and D are not painful conditions in themselves. Question 19. The most common lethal cancer in males between their 5th and 7th decades is A. Cancer of the prostate, B. Cancer of the lung, C. Cancer of the pancreas, D. Cancer of the bowel. Answer: B. Cancer of the lung. The incidence of lung cancer is also rapidly rising in women. Question 20. Of the 4 basic cell types of lung cancer listed below, which is always associated with smoking? A. Adenocarcinoma, B. Squamous cell carcinoma epidermoid. C. Undifferentiated carcinoma. D. Bronchoalveolar carcinoma. Answer: B. Squamous cell carcinoma epidermoid. Textbooks of medicine and nursing classify primary pulmonary carcinoma somewhat differently. However, most agree that squamous cell or epidermoid carcinoma is always associated with cigarette smoking. Question 21. Chemotherapy may be used in combination with surgery in the treatment of lung cancer. Special nursing considerations with chemotherapy include all but which of the following? A. Helping the client deal with depression secondary to the diagnosis and its treatment. B. Explaining that the reactions to chemotherapy are minimal. C. Careful observation of the foresight of the administration of the drugs. D. Careful attention to blood count results. Answer: B. Explaining that the reactions to chemotherapy are minimal. There are numerous severe reactions to chemotherapy such as stomatitis, alopecia, bone marrow depression, nausea and vomiting. Options A, B and D are important nursing considerations. Question 22. Which of the following operative procedures of the thorax is paired with the correct definition? A. Pneumonectomy, removal of the entire lung. B. Wedge resection, removal of one or more lobes of a lung. C. Decortication, removal of the ribs or sections of ribs. D. Thoracolplasty, removal of fibrous membrane that develops over visceral pleura as a result of emphysema. Mr. Liberatore, age 76, is admitted to your unit. He has a past medical history of hypertension, DM, hyperlipidemia. Recently he has had several episodes where he stops talking in mid-sentence and stares into space. Today the episode lasted for 15 minutes. The admission diagnosis is impending CVA. Answer: A. Pneumonectomy, removal of the entire lung. Wedge resection is removal of part of a segment of the lung. Decortication is the removal of a fibrous membrane that develops over the visceral pleura, and thoracolplasty is the removal of ribs or sections of ribs. Question 23. The episodes Mr. Liberatore has been experiencing are probably A. Small cerebral hemorrhages. B. TIAs or transient ischemic attacks. C. Secondary to hypoglycemia. D. Secondary to hyperglycemia. Answer: B. TIAs or transient ischemic attacks. A TIA is a temporary reduction in blood flow to the brain, manifesting itself in symptoms like those Mr. Liberatore experiences. Although hypo and hyperglycemia can cause some drowsiness and/or disorientation, the episodes Mr. Liberatore experiences fit the pattern of TIA because of his quick recovery with no sequelae and no treatment. Question 24. Mr. Liberatore suffers a left-sided CVA. He is right-handed. The nurse should expect A. Left-sided paralysis. B. Visual loss. C. No alterations in speech. D. No impairment of bladder function. Answer: B. Visual loss. Visual field loss is a common side effect of CVA. In right-handed persons the speech center Broca's area is most commonly in the left brain. Because of the crossover of the motor fibers, a CVA in the left brain will produce a right-sided hemiplegia. Thus, Mr. Liberatore will probably have some speech disturbance and right-sided paralysis. Often bladder control is diminished following CVA. Question 25. Upper motor neuron disease may be manifested in which of the following clinical signs? A. Spastic paralysis, hyperphlexia, presence of Babinski reflex. B. Flaccid paralysis, hyporphlexia. C. Muscle atrophy, fasciculations. D. Decreased or absent voluntary movement. Answer: A. Spastic paralysis, hyperphlexia, presence of Babinski reflex. Options B, C and D describe lower motor neuron disease. Question 26. During your assessment of Julie, she tells you all visual symptoms are gone but that she now has a severe pounding headache over her left eye. You suspect Julie may have A. A tension headache. B. The aura and headache of migraine. C. A brain tumor. D. A conversion reaction. Answer: B. The aura and headache of migraine. The warning sign or aura is associated with migraine, although not everyone with migraine has an aura. Migraine is usually unilateral and described as pounding. Julie's symptoms are most compatible with migraine. Question 27. You explain to Julie and her mother that migraine headaches are caused by A. An allergic response triggered by stress. B. Dilation of cerebral arteries. C. Persistent contraction of the muscles of the head, neck and face. D. Increased intracranial pressure. Answer: B. Dilation of cerebral arteries. The vascular theory best explains migraine and often diagnosis is confirmed through a trial of ergotamine, which constricts the dilated, pulsating vessels. Question 28. A thorough history reveals that hormonal changes associated with menstruation may have triggered Julie's migraine attack. In investigating Julie's history, what factors would be least significant in migraine? A. Seasonal allergies. B. Trigger foods such as alcohol, message, chocolate. C. Family history of migraine. D. Warning sign of onset, or aura. Answer: A. Seasonal allergies. Sinus headache often accompanies seasonal allergies. Many factors may contribute to migraine. Usually the client comes from a family that has migrated, which may have been called sick headache due to accompanying nausea and vomiting. Often there is an aura. Stress, diet, hormonal changes, and fatigue may all be implicated in migraine. Question 29. A client with muscle contraction headache will exhibit a pattern different for Julie's. Which of the following is more compatible with tension headache? A. Severe aching pain behind both eyes. B. Headache worse when bending over. C. Band-like burning around the neck. D. Feeling of tightness temporally, occipitally, or in the neck. Mr. Snyder is admitted to your unit with a brain tumor. The type of tumor he has is currently unknown. You begin to think about the way brain tumors are classified. Answer: D. Feeling of tightness temporally, occipitally, or in the neck. Options A and B describe sinus headache. Option A may also be compatible with headache secondary to eye strain. Option B is also compatible with migraine. Option C would be correct if stated a band-like tightness around the head instead of burning. Question 30. Glioma is an intracranial tumor. Which of the following statements about gliomas do you know to be false? A. 50% of all intracranial tumors are gliomas. B. Gliomas are usually benign. C. They grow rapidly and often cannot be totally excised from the surrounding tissue. D. Most glioma victims die within a year after diagnosis. Answer: B. Gliomas are usually benign. Gliomas are malignant tumors. Question 31. Acoustic neuromas produce symptoms of progressive nerve deafness, tinnitus, and vertigo due to pressure and eventual destruction of A. CN5, B. CN7, C. CN8, D. The asicles. Answer: C. CN8. CN8, the acoustic nerve or vestibulocochlear nerve, is the most commonly affected CN in acoustic neuroma, although as the tumor progresses CN5 and CN7 can be affected. Question 32. Whether Mr. Snyder's tumor is benign or malignant, it will eventually cause increased intracranial pressure. Signs and symptoms of increasing intracranial pressure may include all of the following except A. Headache, nausea, and vomiting. B. Papilledema, dizziness, mental status changes. C. Obvious motor deficits. D. Increased pulse rate, drop in blood pressure. Answer: D. Increased pulse rate, drop in blood pressure. As ICP increases, the pulse rate decreases and the BP rise. However, as ICP continues to rise, vital signs may vary considerably. Question 33. Mr. Snyder is scheduled for surgery in the morning, and you are surprised to find out that there is no order for an enema. You assess the situation and conclude that the reason for this is A. Mr. Snyder has had some mental changes due to the tumor and would want an enema terribly traumatic. B. Straining to evacuate the enema might increase the intracranial pressure. C. Mr. Snyder had been on clear liquids and then was on PO for several days, so an enema is not necessary. D. An oversight and you called the physician to obtain the order. Answer: B. Straining to evacuate the enema might increase the intracranial pressure. Any activity that increases ICP could possibly cause brain herniation. Straining to expel an enema is one example of how the increased ICP can be further aggravated. Question 34. Postoperatively Mr. Snyder needs vigilant nursing care including all of the following except A. Keeping his head flat. B. Assessments Q1 half hour of luck, versus, papillary responses, and mental status. C. Helping him avoid straining at stool, vomiting, or coughing. D. Providing a caring, supportive atmosphere for him and his family. Answer: A. Keeping his head flat. Postoperatively, clients who have undergone craniotomy usually have their heads elevated to decrease local edema and also decrease ICP. Question 35. Potential post-intracranial surgery problems include all but which of the following? A. Increased ICP. B. Extracranial hemorrhage. C. Seizures. D. Leakage of cerebrospinal fluid. Mrs. Hogan, a 43-year-old woman, is admitted to your unit for cholecystectomy. Answer B. Extracranial hemorrhage. Hemorrhage is predominantly intracranial, although there may be some bloody drainage on external dressings. Increased ICP may result from hemorrhage or edema. CSF leakage may result in meningitis. Seizures are another postoperative concern. Question 36. You are responsible for teaching Mrs. Hogan deep breathing and coughing exercises. Why are these exercises especially important for Mrs. Hogan? A. They prevent postoperative atelectasis and pneumonia. B. The incision in gallbladder surgery is in the subcostal area, which makes the client reluctant to take a deep breath and cough. C. Because she is probably overweight and will be less willing to breathe, cough, and move postoperatively. Answer B. The incision in gallbladder surgery is in the subcostal area, which makes the client reluctant to take a deep breath and cough. Option A is true. The rationale for deep breathing and coughing is to prevent postoperative pulmonary complications such as pneumonia and atelectasis. However, the risk of pulmonary problems is somewhat increased in clients with biliary tract surgery because of their high abdominal incisions. Option C assumes the stereotype of the person with gallbladder disease, fair, fat and furry, which is not necessarily the case. Splinting the incision with the hands or a pillow is very helpful in controlling the pain during coughing. Question 37. On the morning of Mrs. Hogan's planned cholecystectomy, she awakens with the pain in her right scapular area and thinks she slept in poor position. While doing the pre-op checklist, you note that on her routine CB report her WBC is 15,000. Your responsibility at this point is A. To notify the surgeon at once. This is an elevated WBC indicating an inflammatory reaction. B. To record this finding in a prominent place on the pre-op checklist and in your pre-op notes. C. To call the laboratory for a stat repeat WBC. D. None. This is not an unusual finding. Answer A. To notify the surgeon at once. This is an elevated WBC indicating an inflammatory reaction. A WBC count of 15,000 probably indicates acute cholecystitis, especially considering Mrs. Hogan's new pain. The surgeon should be called as he or she may treat the acute attack medically and delay the surgery for several days, weeks, or months. Question 38. Mrs. Hogan is scheduled for surgery 2 days later and is to be given atropine 0.3 mg IM and Demerol 50 mg IM 1 hour preoperatively. Which nursing actions follow the giving of the pre-op medication? A. Have her void soon after receiving the medication. B. Allow her family to be with her before the medication takes effect. C. Bring her valuables to the nursing station. D. Reinforce pre-op teaching. Answer B. Allow her family to be with her before the medication takes effect. Options A, C and D should all take place prior to administration of the drugs. The family may also be involved earlier but certainly should have that time immediately after the medication is given and before it takes full effect to be with their loved ones. Good planning of nursing care can facilitate this. Question 39. Mrs. Hogan is transported to the recovery room following her cholecystectomy. As you continue to check her vital signs, you note a continuing trend in Mrs. Hogan's status. Her BP is gradually dropping and her pulse rate is increasing. Your most appropriate nursing action is to A. Order whole blood for Mrs. Hogan from the lab. B. Increase fluid rate of infusion and place in Trendelenburg position. C. Immediately report signs of shock to the head nurse and/or surgeon and monitor versus closely. D. Place in lateral Sims position to facilitate breathing. Answer: C. Immediately report signs of shock to the head nurse and/or surgeon and monitor versus closely. These are signs of impending shock, which may be true shock or reaction to anesthesia. Your most appropriate action is to report your findings quickly and accurately and to continue to monitor Mrs. Hogan carefully. Question 40. Mrs. Hogan returns to your clinical unit following discharge from the recovery room. Her vital signs are stable and her family is with her. Postoperative leg exercises should be initiated. A. After the physician writes the order. B. After the family leaves. C. If Mrs. Hogan will not be ambulated early. D. Stat. Answer: D. Stat. Leg exercises, deep breathing and coughing, moving, and turning should begin as soon as the client's condition is stable. The family can be extremely helpful in encouraging the client to do them, in supporting the incision, etc. A doctor's order is not necessary, this is a nursing responsibility. Question 41. An oropharyngeal airway may A. Not be used in a conscious patient. B. Cause airway obstruction. C. Prevent a patient from biting and occluding an ET tube. D. Be inserted upside down into the mouth opening and then rotated into the proper orientation as it is advanced into the mouth. E. All of the above. Answer: E. All of the above. An oropharyngeal airway should be used in an unconscious patient. In a conscious or semi-conscious patient, its use may cause laryngospasm or vomiting. An oropharyngeal airway that is too long may push the epiglottis into a position that obstructs the airway. It is often used with an ETT to prevent biting and occlusion. It is usually inserted upside down and then rotated into the correct orientation as it approaches full insertion. Question 42. Endotracheal intubation. A. Can be attempted for up to 2 minutes before you need to stop and ventilate the patient. B. Reduces the risk of aspiration of gastric contents. C. Should be performed with the neck flexed forward, making the chin touch the chest. D. Should be performed after a patient is found to be not breathing and 2 breaths have been given but before checking for a pulse. Answer: B. Reduces the risk of aspiration of gastric contents. Letter A is wrong because an attempt should not last no longer than 30 seconds. Unless injury is suspected, the neck should be slightly flexed and the head extended. The sniffing position. After securing an airway and successfully ventilating the patient with 2 breaths, you should then check for a pulse. If there is no pulse, begin chest compressions. Intubation is part of the secondary survey ABCs. Question 43. When giving bag valve mask ventilations. A. Rapid and forceful ventilations are desirable so that adequate ventilation will be assured. B. Effective ventilations can always be given by one person. C. Cricoid pressure may prevent gastric inflation during ventilations. D. Tidal volumes will always be larger than when giving mouth-to-pocket mask ventilations. Answer: C. Cricoid pressure may prevent gastric inflation during ventilations. Cricoid pressure may prevent gastric inflation during ventilations and may also prevent regurgitation by compressing the esophagus. Letter O may cause gastric insufflation, thus increasing the risk for regurgitation and aspiration. With adults, breaths should be delivered slowly and steadily over 2 seconds. Effective ventilation using bag valve mask usually requires at least 2 well-trained rescuers. A frequent problem with bag valve mask ventilations is the inability to provide adequate tidal volumes. Question 44. If breath sounds are only heard on the right side after intubation. A. Extubate, ventilate for 30 seconds then try again. B. The patient probably only has one lung, the right. C. You have intubated the stomach. D. Pull the tube back and listen again. Answer: D. Pull the tube back and listen again. Most likely you have a right main stem bronchus intubation. Pulling the tube back a few centimeters may be all you need to do. Question 45. An esophageal obturator airway A. Can be inserted by any person trained in ACLS. B. Requires visualization of the trachea before insertion. C. Never causes regurgitation. D. Should not be used with a conscious person, pediatric patients, or patients who have swallowed caustic substances. Answer: D. Should not be used with a conscious person, pediatric patients, or patients who have swallowed caustic substances. Insertion should only be attempted by persons highly proficient in their use. Moreover, since visualization is not required, the O may be very useful in patients when intubation is contraindicated or not possible. Vomiting and aspiration are possible complications of insertion and removal of an O. Question 46. During an acute myocardial infarct A. A patient may have a normal appearing ECG. B. Chest pain will always be present. C. A targeted history is rarely useful in making the diagnosis of D. The chest pain is rarely described as crushing, pressing, or heavy. Answer: A. A patient may have a normal appearing ECG, which is why a normal ECG alone cannot be relied upon to rule out an Chest pain does not always accompany an This is especially true of patients with diabetes. A targeted history is often crucial in making the diagnosis of acute The chest pain associated with an acute is often described as heavy, crushing pressure, like an elephant sitting on my chest. Question 47. The most common lethal arrhythmia in the first hour of an is A. Pulseless ventricular tachycardia. B. Asystole. C. Ventricular fibrillation. D. First-degree heart block. Answer: C. Ventricular fibrillation. Moreover, ventricular fibrillation is 15 times more likely to occur during the first hour of an acute than the following 12 hours, which is why it is vital to decrease the delay between onset of chest pain and arrival at a medical facility. First-degree heart block is not a lethal arrhythmia. Question 48. Which of the following is true about verapamil? A. It is used for wide complex tachycardia. B. It may cause a drop in blood pressure. C. It is a first-line drug for pulseless electrical activity. D. It is useful for treatment of severe hypotension. Answer: B. It may cause a drop in blood pressure. Verapamil usually decreases blood pressure, which is why it is sometimes used as an antihypertensive agent. Verapamil may be lethal if given to a patient with VTAC, therefore it should not be given to a tachycardic patient with a wide complex QRS. Verapamil is a calcium channel blocker and may actually cause P if given too fast intravenously or if given in excessive amounts. The specific antidote for overdose from verapamil, or any other calcium channel blocker, is calcium. Verapamil may cause hypotension. Question 49, atropine. A. Is always given for a heart rate less than 60 bpm. B. Cannot be given via ET tube. C. Has a maximum total dosage of 0.03 to 0.04 mg/kg for in the setting of cardiac arrest. D. When given for, should always be given slowly. Answer: C. Has a maximum total dosage of 0.03 to 0.04 mg/kg for in the setting of cardiac arrest. Only give atropine for symptomatic bradycardias. Many physically fit people have resting heart rates less than 60 bpm. Atropine may be given via an endotracheal tube. Administering atropine slowly may cause paradoxical bradycardia. Question 50. Asystole should not be defibrillated. A. True. B. False. Answer: A. True. Asystole is not amenable to correction by defibrillation. But there is a school of thought that holds that asystole should be treated like VFib, i.e. defibrillated. The thinking is that human error or equipment malfunction may result in misidentifying VFib as asystole. Missing VFib can have deadly consequences for the patient because VFib is highly amenable to correction by defibrillation.
Thanks for watching. Please comment, like and share.